Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher, and I welcome you to the 153rd episode. We also have been nominated for another award on Apple Podcasts and also on Podbean. So thank you very much for those of you that put in for that award for us. We appreciate it. I guess with over 150 episodes, close to 200,000 listeners and downloads, I guess we're doing okay. So also I wanted to mention, I really appreciate all the feedback I got when I mentioned I might go bi-monthly or every other week. And I would say 99% of you said, no, Terry, we need you every Terry Tuesdays. So I heard you, and we will continue the process. So we're going to keep going every Tuesday. So today I'm actually going to start a series, and I don't know how often I'm going to do it, if it's going to be week to week. But like I did the modifier series not too long ago, I'm going to do a specialty series. So that means that I'm going to talk about and spend time with certain services and coding that just has to do with a certain specialty. And today I'm going to focus on gastroenterology. So if you have a certain specialty that you would like spotlighted or focused on the Codecast, just let me know. Send me a quick DM either on LinkedIn or Twitter at TerryCoder1 or on Instagram at TerryNCA, and or even just send me an email at terryfletchercpc@aol.com. And or contact me on my website at terryfletcher.net contact page, and I'm happy to see if we can get your specialty in there and come up with a couple of questions and coding options so that you know how to code for services. But I think it just gets your feet wet sometimes when you're thinking, okay, maybe I want to switch specialties, or actually that is my specialty and I've had questions and I'm just not sure what to do with that. So I want to be able to speak to that and really share with you some of the things that I've learned in the specialties that I teach. And hopefully by sharing this information with you, you can pass it along to someone else as well. Also, please a reminder, if you can, or if you remember, if you could shoot me a review on Apple Podcasts, that would be great, or YouTube, or wherever you listen to your podcast. So they look at those and it trends, and it's just really appreciative. Okay, so let's get started with what we're talking about in gastro. So for gastroenterology, I'd like to focus a little bit on the screening colonoscopies, because I get these questions a lot, and I do a lot of webinars now instead of in-person seminars like I used to. And because of social distancing, and obviously a lot of the hotels where we hold some of our live meetings have been shut down, we've really done a lot of virtual meetings. Well, a lot of those are updates. They're not necessarily, taking it back to basics, if you will. So I want to do that a little bit when it comes to the gastroenterology specialty. And starting with screening colonoscopies, there's always a question mark when it comes to the right code to use, not only when it comes to CPT, but if it's Medicare, is there a HCPCS code, which is the Healthcare Common Procedural Coding System. That's kind of their own system. Some payers actually will recognize what HCPCS says, but some won't. And then what are the ICD-10 codes that correspond or link to those screening colonoscopy services? And just a side note, I know some patients think that there's screening for everything covered, and there isn't. So if a patient says, I want a screening upper GI endoscopy or an EGD, there is no coverage for an upper GI screening anything. So we always have to really kind of bring them back sometimes to the realities of coverages. So first, what is the right code to use for a screening colonoscopy if it's a commercial patient? Well, commercial plans and Medicare patients are different. So Medicaid and commercial plans, they use the code 45378 if that is just the basic, what we call look-see colonoscopy. If it's Medicare, Medicare has HCPCS codes that they use, and it's based on that patient's risk. So G0105, it's a G code. If that patient is a high-risk patient, so they have family history, or they have personal history, or it's a special screening based on the fact that they're maybe age-appropriate. But if they are moderate risk or don't meet the criteria for high risk, then it's G0121. And these codes also have frequency guidelines. So the G0105, you can only use every 24 months. And take that 24 months to basically 24 months and 10 days because Medicare is on top of that and you could get a denial. Now, the 45378, that's your base code. That's in the surgery section of the CPT book. And if you use that code, it means that you didn't do any procedure to remove a polyp. It's, again, just a look-see. They actually call it by brushing or washing, a flexible diagnostic colonoscopy. Also, if you look at any surgical code, and this is just a side note, and it says in parentheses, separate procedure, what that means is that that's the only thing that can be billed that day because it's a separate procedure. It's typically bundled into everything, or I like to call it the base code. So it's the first code in that family of codes, and then it just continues to upcode from there. So, for example, if we did a screening colonoscopy, 45378, or a diagnostic, it could also be diagnostic. Either code it's used interchangeably depending on the circumstance. But let's say for commercial plans, let's say that your physician did a colonoscopy by snare after that look-see. Well, you wouldn't bill the 45378. You would increase your code or up your code, if you will, to 45385 because now there's codes that say now with a snare technique. So that's the section you start in is where the 45378 starts. Now, ICD-10 codes are tricky for screening because there are some payers who feel that screening means that you have no current symptomatology, which is correct, and you might have a family history, or it means that you're age appropriate. But there's also some other payers that say that if you have a personal history, it's no longer a screening. So you need to know what your payers are saying. I can speak to Medicare, and Medicare looks at 4 different codes. So Z12.11, that's a special screening for malignant neoplasms of the colon. And listing that first actually triggers Part B benefits. What that means is that currently Medicare will waive the copay and the deductible for a screening service for colonoscopy. Now, if it becomes a surgical procedure where they have to remove something, then the deductible will kick in. But the 20% will kick in, but the deductible is still waived. But if you have a commercial plan, make sure you're checking their rules. Now, the Z83.71, that's family history of a malignant neoplasm, and that is also on the screening colonoscopy coverage list. Z86.010, personal history, and that's also when you see that the doctor said they're under surveillance. Now, there's another code, and it's Z80.0, and some payers will allow the family history of malignant neoplasm of the digestive organs, but Medicare doesn't. And the reason is that the screening colonoscopy means that you're dealing with the colon, not with the digestive tract. So know when you're reading between the lines, understand the difference between those things to make sure that they know you're really just dealing with the colon area. So an example when we talk about screening, so let's say you have a patient that had an indication for colon screening. They're a 55-year-old female, and basically they're just average risk. They don't have any problem. They just feel that it's age appropriate and time to get a screening. And so they're there for the encounter for colon screening. So that's considered a special screening, the Z12.11. And because they're average risk, if it's Medicare, which it's not because they're 55, it would have been GO121. But since this is a commercial patient, because she's 55, it would be 45378. Now there's a modifier 33 that you can also append, and that shows that it's a preventative service. And so it's helpful to put that on there because, again, that also can help trigger benefits, meaning the out-of-pocket or share of cost for the patient may be waived. Now, another one, let's say we have a personal history of colon polyps. So we know that our ICD-10 code is going to be Z86.010, and the patient's there for colon screening. Now, again, make sure you know your payer because even in the Medicare MAC carriers, there's a national policy and then some of the MAC carriers, so the actual contractors have different rules on this. But if a patient's coming back after 24 months and they've had a clean scan, then they will typically allow that screening for that personal history of polyps. That would be the GO105 if that patient is over 65, and so or Medicare patient. Now, this is an interesting one too, because this is where it comes in as a screening, the patient, or they come in as a screening, and then they end up finding polyps in the cecum or the sigmoid colon. So colon screening, but polyps in the cecum and sigmoid colon were found, so they ended up removing them by snare. So the procedure was colonoscopy with removal of cecal and sigmoid polyps by snare technique. So you've got 45385 now. Now it changes to a surgical code. It's no longer a screening, and that's colonoscopy with removal of polyp by snare. And then if it is Medicare, you would have a PT modifier. That's the modifier 33 crossover. That's the same equivalent. And that reflects that it is a preventative service and it will help trigger benefits. And then you have your first listed code. Now this is important. Z12.11, because they were there for the screening. But your linkage or your pointer to the 45385 goes to the D12.0. That's the benign neoplasm of the cecum, if it turned out to be benign, or D12.5, which is the benign neoplasm of the colon, or the sigmoid, I'm sorry. So you just want to make sure that you have the link to your surgical code that is the D codes that gives you location of that neoplasm, of that when you're taking out that polyp. But you want to make sure that your first listed code, again, I'm going to keep saying that to trigger benefits, is the Z12.11. Because if you don't have that as the first listed code, or the first listed ICD-10 code, then it'll be really tough to get the patients out of pocket, or at least their deductible waived. And they get very mad when they assume that they're coming in for something that their out of pocket is going to be very limited. Which actually brings me to another point. Make sure that you have a clear financial policy for your patients when they come in for screenings. And even if it's not gastro, if it's, mammogram screening or whatever it is, triple aneurysm screening, they need to know that you're going to make every attempt to bill it under the U.S. Task Force, meaning that they may not have an out-of-pocket. But if something is found during the course of this colonoscopy, it now turns into a therapeutic or diagnostic colonoscopy, and now they would still have their 20% or their coinsurance. Medicare will still waive the deductible. Commercial plans, it's contract to contract, just like what we've been dealing with telehealth. They all have their own set of rules. So make sure you know that coverage on what they'll do depending on the payer of the patient. Now, let's say a patient is calling for a screening colonoscopy. They don't have any sign or symptoms. They basically need to just be scheduled for their colonoscopy. Well, a question comes up, and this is probably the biggest question that I get for anything that I do when it comes to gastro, is can a provider bill an E&M visit if a beneficiary is referred for a screening colonoscopy? Well, the answer from Medicare is pretty clear. They put an FAQ on their website in 2014 and also a local coverage policy on several sites. And they basically said E&M services are not separately payable in this circumstance. They said it can be made if the patient had some problem, but this is called what they've adopted as open access, meaning the patient should just be scheduled for their screening. Now, in saying that, there's some practices saying, well, I would never just, go in and see a patient in the holding area and start a screening colonoscopy. It's kind of an intimate procedure, and that's fine. But the problem is you don't have a billable service, because if it's truly a pre-screening visit and the patient doesn't have a problem, then it could be a meet and greet or a cash charge, but it's not something that you're going to be able to bill to an insurance company. So the patient would have to pay for that. And again, you can do that, but it's the patient's responsibility. Now, somebody said, well, Terry, what about that HCPCS code, that buried one that came out in 2016 called an S0285? And that says colonoscopy consultation performed prior to a screening. Well, I've seen that as well. But the U.S. Department of Labor and Treasury and HHS stated that the plan or insurer may not impose a cost sharing with respect to a required consultation prior to a screening procedure, and this is never payable by Medicare. So under the ACA Act, this was created as more of an informational code in nature and really does not have any kind of merit when it comes to reimbursement services. So Medicare does not cover a pre-screening colonoscopy visit prior to a procedure, and nothing has changed on that. And I have people all the time saying, yes, but I get paid. You get paid because you're giving wrong information, or you're telling an insurance payer that you're doing something that isn't correct. You're saying that you're doing a diagnostic. You're not doing a screening. Remember, a screening colonoscopy means the patient has no symptoms. They may have a history of something, but they're coming in because they're age appropriate. So our E&M services, with the exception of our preventative, basically say that those are problem oriented, that the patient's actually complaining of something. That's why you have to have a chief complaint to qualify the E&M service. So then the question comes up, what did I mention? What if I can bill a preventative? Well, if the patient's only coming in for a screening, are you billing for colonoscopy? Are you billing the preventative for the entire, physical exam they're going to have that day? Because if it's only limited to the screening colonoscopy, then that's not appropriate, because those are usually covered under most commercial plans once a year for the yearly exam, or the annual, if you will. So just know that E&M services are tricky when you try to code for them to either establish care or for a meet and greet. You shouldn't be using the E&M, the evaluation management codes that are used for problem-oriented visits. You're supposed to, according to AGA, just schedule them for that actual open access. So just so you know, this comes up quite a bit. I'm going to shift gears a little bit. I had a coding question kind of come up this week, and I appreciate, Christina, you sending this over to me, because it's funny that you had sent it to me, because I got more emails on this right after you sent it. Do you ever try to shop online for something and all of a sudden now that's the advertisement, that's all you see? Well, Christina, who has been a long time podcast listener, she asked me a quick question on the Instagram DM, and I responded, and all of a sudden now I'm on email, and those are like not only the emails, but all the advertisements I'm getting for the same conversations. So you just know somebody's lurking somewhere. But we have a new code, a new CPT code that became effective, and you're allowed to charge for it. Actually, it says October 1st, but I see some people already trying to submit it as of September 1st. But it's a new code, and it's designed to capture PPE now with the pandemic. So what does PPE stand for? Personal Protective Equipment. And this is worn to minimize exposure to hazards that cause serious workplace injuries and illnesses. And we know we've had some issues, of course, with COVID, and what are we supposed to do about it? So what the question was interesting, was, okay, Terry, we want to start charging for this new code. And the code is 99072. And it's only once in person per patient encounter, per provider's UPIN number, regardless of the number of services rendered on that encounter. And you've got a couple of different, instructions from payers. You've got one from Medicare, and then you've got one from CPT, which they actually put it into a CPT assistant, which I actually thought was kind of amusing. And I'll let you know why, because of something they said. I was like, really? You're actually going to tell us that? So here's what we found as far as the gist of when you can code for that. So it says guidance, and this is where it gives you some guidance. It says reports the provision of additional supplies such as face masks and cleaning supplies, reports clinical staff time for activities such as pre-visit instructions and office arrival symptom checks. It's reported only once in person, I mentioned that, regardless of how many services. And it's in addition to, if you're also billing for, when they said the nurse visit, for the actual quick check or the counseling to tell the patient that, this is, you need to sequester or you need to quarantine, blah, blah, blah. And it says it may be reported when additional clinical staff duties are performed by the physician or other qualified healthcare professional in lieu of the clinical staff. So here is something that came out that was directly from CPT Assistant. And I thought this was interesting, and you'll see what I mean. So they gave you 3 bullets, and so you'd have to have this documented to be able to bill for it. It said time over what is included in the primary service of clinical staff time. So registered nurse, RN, LPN, medical assistant, to conduct a pre-visit phone call to screen the patient. So symptom check, provide instructions on social distancing during the visit, check patients for symptoms upon arrival, apply and remove PPE, and perform additional cleaning of the examination procedure, imaging rooms, equipment, and supplies. The second bullet says 3 surgical masks. Why not 1 or 2? Why 3? I don't know where they came up with that, but I was just like, okay, so if you don't have 3 surgical masks in that encounter, then you can't code for it. But just so you know, it says that. And then the third bullet says cleaning supplies, including additional quantities of hand sanitizer, disinfecting wipes, sprays, and cleansers to further delineate the use of code 99072. And it also has a parenthetical note that 99070 directing users to the new code to instead of reporting any kind of materials under the 99070. So it's really interesting because I've seen a couple of payers that are only paying about $18 for this. So they also said that when you're talking about time or practice time, it's saying in an instance in which the clinical staff activities are performed by a physician or other qualified provider, the activity requirements of this code would be considered as having been met. However, the time spent should not be counted in any other time-based visit or service reported during the same encounter. So this is above and beyond of anything that's already been part of a time-based code. So if you're basing your visits right now on time, or anything you're doing is based on time, then you can't report this 99072. Now, Medicare is hit or miss. I'm finding that most of the Medicare payers are not paying for it, but many of the commercial plans are. So the question came up, and I think this is what Christina was asking me. She says, okay, so we're trying to bill for this, and how many payers are paying for it or not. Well, I was making sure that I cautioned her, and I want to caution you as well. Remember, and I've mentioned this before, but sometimes not everybody is clear. When you bill for a service to a payer, you expect to get paid. You don't hope to get paid. So let's say you're trying to bill United Healthcare. That's one plan I know that isn't covering it for the 99072. And let's say you bill $25. And they come back on their explanation of benefits and say, this is not medically necessary and that we're not going to cover it. So at that point, what do? Do you basically write it off, or is it the patient's responsibility? Check your EOB, because you're not supposed to write off anything that you're trying to get paid on. You remember it. I've commented on this before. You can't just throw spaghetti at a wall and hope it sticks. If you're billing for anything, it means you expect to get paid, not that you hope to get paid. And so if you want that money, it means you want it not just from an insurance payer, but you want it from the patient. You just want it, period. And so that's why you have to be clear that if you've decided as a practice to add this extra charge, first of all, you need to alert your patients. Put up signs, put it on your website, let them know. Due to current pandemic and coronavirus expense, we will be now adding an extra charge to any physical encounter for PPE. Explain what that is, and the charge will be. Please note, not all payers pay for that, and so if it is not covered or not paid, you'll be responsible for that charge. Thank you for understanding. And most patients will, I hope, are appreciative of the fact that you're trying to keep them safe and protected, and that your practice is doing their due diligence in making that happen. So just make sure that you are looking at the CPT assistant on this. Make sure that you're looking at Medicare's website, and make sure that you look up on the American Medical Association. Also, look at ICD-10monitor.com and look it up as well, because we have it on there, and that should really help you to find some of the guidelines there as well. It was a story that we reported on September 15th, and so you'd be able to find it on there. Okay, so now my personal tidbit. Football's back. I'm so happy right now. I can't even stand it. We won our first game. Big Ben Roethlisberger won his Monday Night Football game, and I'm happy. All my fantasy football teams, I won, and so now I'm going into Sunday excited, and I'm actually recording this right now on Friday. So you'll find out from me the week after next if I really liked it or not, or if I'm really bummed. But just know that I'm excited, because it just is such a good thing to get just something back that's normal. I'm really kind of over the last 8 months. I don't know about you, but I'm ready to move on from 2020. I'm at least ready to have the election over. So just a public service announcement, go vote. If you haven't yet, you definitely need to find a way to do that. So the only way that we can make sure things happen the way that we want to is to take part in it and to have a voice. So hopefully you are registered to vote. All right, everyone. I hope you make it a great day and make it a great week. and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.